Ye, welcome to the AGM. Thank you for coming to talk with us. And as we say, we'll do Q&A at the end.
Yeah.
So I will hand over to you and say thank you.
Sure. Okay. So. Right. Oh. So good afternoon, everyone, and it's a pleasure to come to Birmingham and meet and join this meeting. And so thanks to Adam and Ains for the invitations to do a mini presentations about HSP. So I'm a consultant neurologist and I practice at Royal Victoria Infirmary in Newcastle. So what I'm hoping to cover today is really just to have an overview about HSP, which many of you probably have very good knowledge. So just a recap for people who already know it a lot, but for people who are relatively new to their journey, maybe this is a good introduction to the condition. So this is what I'm hoping to cover today. And just a reminder what the common symptoms and many of you experience on a day-to-day basis. And maybe one slide to cover. Sometime you may come across a label of HSP plus. What is it all about? And we talk about what can we do in terms of measure severity in a clinical practice, and some symptoms that probably matter to many of you, but probably often do not have enough time to discuss at clinic. And maybe just one slide about what is the current landscape in terms of therapies in HSP. So to talk about HSP, is probably important to know that all the voluntary movements, any movements that we do, moving our arms, moving our legs, receive information from the brain. So the brain tells the muscles what to do. So for the muscles, as you can see here, so that is a reflex, which means that when the muscle is stretched, they send information to your spinal cord, and then it will send information to the muscles to contract. So this movement is a reflex, but in order to fine-tune this so that we don't overdo it, the brain needs to send the signals down to that level of the spinal cord and say, don't overdo it. So that is what would happen in normal individuals without any HSP. The muscles will contract and have maintained the tensions, not too much, not too little. For individuals who suffer from HSP, the cables that send signals from the brain to the spinal cord has some damage. Either the cable is not formed properly or there's some degenerations. And as a result, the braking system from the brain is not working. So when the muscle is stretched, and then the next thing is the muscle will contract. But because you don't have the braking system, the muscle will just keep contract and contract and contract. And that results in increased muscle tone, which is what we often refer as spasticity. So your legs are very stiff, and sometimes if you stretch it, it seems to contract and shaking and spasm. And that's because the cable system is affected because of the HSP. And it tends to affect the longest nerve cables. So which means that if you think about in our body, from the brain to the legs, that is probably the longest cable. And that is why people with HSPs are always legs are affected. Arms are relatively spare for that reason. In addition to the spasticity, and sometimes people can also develop weakness in their legs, especially with the hip muscles. So hence the word para, which means both. Both legs have weakness, paraplegia or paraparesis. So these are the core symptoms that are affecting the muscles, probably in most or if not all people with HSP. We talk about HSP plus, which means that in addition to muscle weakness and spasticity, maybe 1 in 10 individuals can have additional problems. That's what we call HSP plus. But who develop HSP plus is really depends on what the genetic problems are. So currently there are more than 100 genes been implicated to cause HSP. But overall, if you look at every single patient with HSP, only about 10% of them have more complex problem, additional problems. It could be additional movement problems. So you can have something look like Parkinson's problem, dystonia, or you can have nerve damage, so you can have sensory problems, or you could have seizures, something more serious. But this affects much smaller number of individuals, and it really depends on what the genetic is. In terms of how do we manage symptoms related to HSP, the best things to do is actually through a multidisciplinary team MDT input. So you will see GP, you get referred to see a neurologist or pediatricians will assess what the symptoms are. If the spasticity in both legs is interfering with your activities of daily living, impairing your functions, causing lots of pain, this will be the time to talk about maybe we need to think about medications that can help with the spasticity. The most common one is oral tablet. So some of you may still be taking it or have tried before, things like baclofen, tizanidine, or carbapenem. So these medications can work, but sometimes when the dose being pushed up, you start experiencing side effects. It could be like dizziness and feel like lots of brain fog, very foggy, and lots of people don't like it when the medication are pushed up. So we then would think about, if we examine your muscles in your legs, sometimes certain muscle groups seems to be more affected, much tighter than the others. And for those individuals, Botox injections could be a consideration. And in a much smaller number of individuals, if they have very significant spasticity, and in certain neuroscience center, they may offer treatments called intrathecal baclofen therapy. But again, that is very restricted to where you live, where your nearest regional neuroscience center is, and whether they have such service. So that is spasticity management, but it always goes hand in hand with physiotherapy input. So many of you would remember, especially children or teenagers or young adults, oh, seeing physios again, is it going to ask me to stretch? And stretching exercise is something that many people don't like because it's quite boring, really is boring. And sometimes it can be a bit painful. But the purpose of the stretching exercise, if you remember, spasticity is the muscle overcontracted. So some muscles overcontracted. So if you think about your knee, for example, if the knee is constantly being kind of pulled out because the muscles overcontract, stretching is trying to make sure that the joint retains the movement so that you can have a more neutral joint movement. So stretching is really trying to prevent development contractures, which may further limit your functions in the future. So it is a long-term investment doing stretching exercise. You don't see the immediate benefit, but that is a rationale behind it's really try to preserve your joint movement as much as possible. And the physios can also advise you on different things. For example, many people feel quite wobbly and unsteady because of the stiffness, because of the weakness. Physios can give you some advice in terms of train your other muscles, activate your core muscles, maintain the posture. Occupational therapist perhaps is also someone that you have seen in your life or have met a few times. So occupational therapists really have the expertise of, because you have this problem with HSP, what can they advise you in terms of preserving your function or try to utilize whatever function you still have to live as normal life as you could. So considerations would be things like a walking aid, a stick, a frame, and if the weakness becomes so significant that it no longer safe for you to try to stand and walk on your own, a chair can be considered. And some adaptations at home make your life easier, having handrail in stores. So occupational therapists actually play quite a significant role in many patients with chronic conditions, including HSP. Because of the natures of how you are affected with the muscles, when you walk in a very unique walking patterns, right? So the legs turn in, and then you always almost end up tiptoeing. And orthotics is potentially give you a footwear to try to make your gait or your walking patterns more comfortable, so that it's not just tiptoe, because lots of people say, well, I change my shoes very often because it just get worn out very quickly. And then having some insoles or footwear potentially would correct that partially and make your walking hopefully more efficient. It doesn't work for everyone, but often the orthotist will work with you, try to develop some bespoke footwear to try their best to try to make sure that you find a footwear that works for you. One thing that perhaps people wouldn't generally volunteer in clinic, but actually can be significantly affecting your day-to-day living is the bladder symptoms. So this is actually, according to various different papers, up to 70% of people experience some kind of bladder symptoms. If you remember, the brain send the signals to the spinal cord and then go to your muscles, same as the brain also sends signals to control your bladder function. So if you think about bladder, essentially is like a storage space, and then you have a sphincter, which is like a tap. So in the normal circumstances, the bladder will fill up, and then you send the signal to the brain, and then you go to empty your bladder. But when you have HSP, that signals control is not 100%. So the bladder sometimes get a bit confused and say, am I receiving signals from the brain or not? So it feels like you have to keep going to toilet. So that is what we call the urgency and frequency. And some people would say, I go to the toilet, but I couldn't pee properly. That is because the sphincter, the tap, is also getting a bit confused. So the sphincter is closing when they should be opening. So some people will say, not only I have the storage problem, I need to keep going, and then I feel that I couldn't hold properly, but also I find it difficult to pee. So these symptoms could be a combination of all, or could be some of them. And sometimes that when you see a GP and then they say, it's best that you get further investigations. So you might see a urologist, which study the kidneys and the bladder, and then you will get referred to a urodynamic study. So if you have that done before, you know precisely what it involves. It's not particularly pleasant, but it can actually give quite a lot of information and to confirm actually this is what we call a neurogenic bladder or overactive bladder. Because for men of certain age, prostate can be under problems, can kind of cause all these other symptoms we just described. So able to tell, is this a prostate problem? Is this a bladder problem is actually quite important. And that will inform how we manage the symptoms as well. So there are quite a few medications available that can treat these overactive neurogenic bladders. So medications such as oxybutynin, sulfasalazine, and then there's other things called maribagron. So really depends on what your other health status, and sometimes your GP or your urologist or neurologist may suggest different medication. It's really just to juggle, if I give you these medications, can I minimize other side effects that come with these medications? When things do not work, especially if something to do with the sphincter, the tap, if the tap is constantly closing, then the urologist can give the Botox to the sphincter and then actually make the peeing a bit easier. So if you do develop bladder symptoms, don't suffer in silence. Do speak to your GPs or speak to your specialists because there are treatments available if you haven't tried any. So this studies is conducted by Eng, who's actually on the floor. So looking at how common HSP is in England and in Northern Ireland. So these studies look at the data covering from year 2000 to 2021. You see the number of HSP. Oh, sorry. Oh, sorry. Okay. Yeah, thanks. Thanks for the tip. So you see so this is study covering from year 2000 to 2021. So about year 2000s, the prevalence based on the data of the GP's surgeries data is about 3 per 100,000. And then fast forward 20 years later, that number appears to double to 6 per 100,000. think there are multiple potential reasons why this is the case. And so one, it could be actually is a much better recordings of HSP. Year 2010, 2015, 2020, the awareness is much higher. The coding is better compared to at the beginning. But it also probably means that actually most people with HSP have very normal life expectancy. So people who diagnose in their 50s live into their 80s. And so people who are a child and then live into adulthood. And therefore, the number of cases accumulated with time. So the prevalence and the number 6 per 100,000 is probably comparable to other European studies. So still rare, but perhaps not as rare as other conditions that could be 1 in 1 million. This is 6 per 100,000. Okay. So don't worry, this slide, Lorenzo's will cover more about the genetic side of HSP. The important thing is there's more than 100 genes involved. And sometimes people often ask me, what is the point of knowing the genes when you can do nothing about it, right? So all of us seem to have a very similar problems. What do you gain by knowing what genes do I have? First of all, it tells us about inheritance pattern, how the gene is involved, inherited. Is it a dominant, which means that you just need 140 genes, or is it recessive, you need 240 genes, or is it X-linked? But perhaps from the molecular and science perspective, if we know what the mechanism goes wrong affecting the cable, why the cable degenerates, why the cable is not repairing, if we know the mechanism, that could potentially unlock access to treatment development. So informations like this, whilst you may not affect or influence your care at the individual level, but in a longer run, potentially can tell us more about how people change with time, how individual genes behave, and hopefully it will actually unlock access to treatments and specific treatments. As clinicians, and I get asked by patients all the time, how severe is my HSP and how fast has it changed? So in clinical practice, there's clinical rating scale that's developed more than 20 years ago. And you can look at the questions on the right side. It's all fairly practical and relevant to most of you. How you walk, how fast you walk, whether you can climb the stairs okay. Do you have weakness to get up from the chair? And do you have pain? Do you have bladder symptoms? So by repeating assessment in a measure and objective way, as objective as possible, consistently, it actually can help us to check or map or chart how your condition change with time. So maybe just focus on the graph C, right? So the red color, the top line, refers to individuals with complex HSP. So that HSP plus. And then the blue line is for uncomplicated, or what we call pure HSP. And the y-axis, the straight line here, is the severity kind of created by that rating scale. And then as you see that as time goes on, people with pure HSP, their disease severity seems to be fairly static. Once you reach a level of deficit, you do not necessarily notice much changes yourself. It's like, oh, it just stayed the same. But for people with complex HSP, you see that the disease severity continue to climb. So that actually come back to the disease severity in complex HSP is probably driven by what are the features that you have. It could be due to you have additional symptoms like Parkinson problem, ataxia, unsteadiness due to the cerebellum problem, dystonia or seizures or cognitive problem. So this is telling us that by knowing what genes you have, then actually we somehow can have some ideas how your conditions may change. Not sure what if I click. Phew. So we talk about the clinical symptoms or clinical features that clinician or neurologists like myself are particularly interested. But actually, I'm sure many of you have additional problems other than spasticity and weakness. So the individual lines I've highlighted in a purple line is highlighting the symptom perhaps matters to a lot of you, but actually not discussed a lot of the time. This could be because, well, there's not enough time in a 20 minutes clinic appointment with examinations, everything's in a rush. But maybe it's also because it's something that has been under research and actually the clinicians are not quite sure how best to discuss them with you or how to advise you. And this would be including symptoms like fatigue. So many people experience that, but it's an area that has not been very well investigated or researched. Or it could be, well, looking beyond the symptoms of you have weakness, actually, how does it affect me at the individual level, my hobbies, my leisure activities? Things like that are often not discussed, but matters to a lot of you. So why is it matters to know patient perspective? Because you live with the conditions, of course, your perspective matters. But also, if you think about if we were to develop a new therapy for you all, the clinician's perspective is important, but how it relates back to your day-to-day life also matters hugely. So there is a lot of research actually try to look into how do we develop measures from patient perspective, what do they think is most relevant? And that is this quality of life that's been developed fairly recently, and then that cover 5 domains, as you can see here. You know, your quality of life, your attitude to your day-to-day living, your mobility, how you perceive the care you receive, how it affects your social life, your work, and other associated symptoms. But interestingly, despite this skill has fairly recently developed, 2 particular common problems are not really featured. It is fatigue, it is sleep. And part, I think, is actually telling us we don't really know how best to quantify or measure fatigue in not just in HSP, actually in many other forms of conditions. We don't really know what is the best way to measure it. And in part, we also don't really know what is causing fatigue to start with. And this slide is really just to say that other than what the clinician says, what you say, there's different ways we can measure the impact of HSP. So we can use some laboratory method to measure your walking pattern, gait analysis. You can do it at the laboratory, or you can use a wearable sensors, such as in this graphical area there, you can wear it at the back, you can wear it on your feet, and then this will allow quantifications of how your walking pattern looks like. And again, the reasons that this is relevant is really in anticipations of if there is any treatment trials, we can use sensitive measure like this gait analysis. Potentially, we can have a much smaller sample size, maybe a shorter duration of the studies because these sensors can detect changes that clinicians cannot see or you may not necessarily feel. But this is still an early work, and there's lots of, yes, the HSP patient walk differently compared to healthy control, but we haven't really had much data in terms of how does your walking pattern change with time. And I like this infographics, and so you may remember this infographics is actually prepared by Adam, and this infographic is available on the European Reference Network of Rare Neurological Disorder, which include HSP. But what this infographic really is summarizing is depends on the journey of your HSP. You may be at the beginning of actually, I have symptoms, that is suspicions, but because maybe there's low awareness of the condition, there is poor awareness of actually there's different ways that you can investigate genetically, then you kind of stuck in the conundrum of what is the answer. But once you got a diagnosis, people who have lived with it actually focus more on actually what can I do to help myself to stay as fit as possible? What else is there? Can I take part in clinical trials? So the journey lays out different challenges, but in certain way, when there are challenges, it also means that the researchers need to think about what the solutions could be. But we can't do it without working with the patients, because ultimately we need to do research that matters to you most, rather than I think this is a good idea. You might say, no, this is rubbish. It doesn't matter to me. So this is my last slide. So whilst there is quite a lot of promises, especially I guess in the last 10, 15 years, we have huge breakthrough in terms of finding out a lot of rare genes that cause HSP. The number has jumped from maybe less than 10, 20 years ago. Now it's nearly 100. So that is great. But what is holding in terms of therapies? Other than Botox, other than baclofen, is there anything new? I suspect this is probably many of you are interested to know. At a preclinical level, i.e. at a laboratory level, there are many research going on. There's lots of interest and attempts in terms of gene therapy, because HSP is a genetic condition. The holy grail is if we can correct what the blueprint problem, surely we can mitigate all the downstream problems caused by the gene problem. So that is the holy grail. But it is a very costly approach, because let's face it, if you have 100 genetic problems, one gene therapy costs more than $1 million, for example, right? Where do we find this money? And where do we find these patients? What are the unknowns in terms of the safety of this gene therapy? So while it comes with high promise of efficacy, it also comes with financial costs and also safety concern. So that is one way that we can approach how we can treat HSP in the future. On the other hand, drug repurposing means, well, we already have a lot of medicinal products that we have created in the last 50, 60 years. There's many drug companies have libraries of thousands and thousands of compounds. If we know the mechanisms of HSP better, surely some of this compound can address those mechanisms. So because this compound have already passed through some trials for other indications, it will be cheaper to pursue trials. It can potentially help more individuals because it's not specific to one gene. You can potentially target more genes, but then the efficacy potentially will be reduced because it's not specific to that gene problem. So this approach also comes with its own challenges. But I don't think we should lose hope, because there's lots of interest and things that can be proven potentially promising. Then the next thing is to come to clinical trials. In order to come to clinical trials, we need to know what to measure, what your views are, and what other things we can do to measure changes. So everything's come in a loop, right? So you cannot just do one thing without the others. So if there's any clinical studies you feel that you like to take part, go ahead if that suits you and is that safe for you to do. And that is just my talk.